Am I visible and audible? Good afternoon, everyone. Hello. So, good afternoon, everyone. Just type in the chat box whether this screen is visible or not. I am audible or not. Everything. Okay. Yes. Okay. So, shall we start now? Okay, without wasting any more time, let's start with the next part of the GIT section. Okay. So we have completed the esophagus. Okay, we have completed the liver, pancreas, gallbladder, and the esophagus. Now, today I will do the next part that is about the stomach and the duodenum, and then we will move forward. Okay, so just I'm not going to the anatomy. Let's move to the this part. So the first question they can ask about the H. pylori. Okay, so this is the how the bacteria looks. It is a spiral or the curved like, and they have multiple flagella, which helps to move through the mucus. So suppose this is a stomach, okay, and this is an esophagus. So if there is an like H. pylori bacteria, they can easily move it through this region and enters into the stomach. Okay, so they are gram-negative bacteria. Remember, what are the disease caused by the H. pylori? The most common is the duodenal ulcer. Okay, so 90% of the cases, 90% of the cases, the most common cause for the duodenal ulcer is H. pylori bacteria. Okay, and followed by the gastric ulcer, which is about 75 percentage. Okay. Other than this, chronic gastritis, gastric carcinoma, usually H. pylori bacteria, it produced gastric adenocarcinoma. Okay, which type of the cancer? Adenocarcinoma of the stomach. Okay, so this can be one of the MCQ. Most common cause for the renal ulcer, H. pylori. Yes. And what is the most common site of the H. pylori bacteria? This is your gastric antrum. So most commonly, the H. pylori colonization takes place in which part of the stomach? Your answer will be the gastric antrum. Okay, it is a gram-negative bacteria. It has multiple flagella. Okay, so this are few short questions they can ask you in the examination. Now, how this H. pylori enters into the stomach? It enters through the mouth, usually during childhood, and then reaches into the stomach. You know that the stomach is highly acidic and its pH is about 1 to 2. This is one of the questions they can ask. If I'm going too fast, let me know in the chat box. Okay. But H. pylori, they even survive. Why they survive? Because they are producing one enzyme known as urease. Okay, that is why in case of H. pylori bacteria, in case of duodenal ulcer or H. pylori, to know whether there is an H. pylori colonization is there or not, we used to there is this rapid urease test. Okay, rapid urease urease test. So this test is the gold standard diagnosis for the H. pylori bacteria. Okay, what is the gold standard diagnosis for the H. pylori bacteria, whether there is an H. pylori colonization has taken place in the stomach? The answer will be your rapid urease test. Okay, H. pylori, they enters into the stomach, but even the stomach is acidic in nature. If the acid is there, then they kill the germs and the bacteria. But H. pylori still survive because of the producing an enzyme called urease, which break down the urea into ammonia and the carbon dioxide. Okay, so that is why whenever there is a problem, usually in conventional mode of the treatment, they give a kit, okay, for the 1 month or 3 month kit of which is usually for this destruction of the H. pylori bacteria. And after the treatment of H. pylori, usually in the conventional, not in the homeopathic mode of the treatment, after they do the urea breath test to know how is the treatment like is processed. Okay, urea breath test, this is after the treatment. Okay, now see, now H. pylori colonization, when the H. pylori enters into the stomach, they decreases the somatostatin, which is in one type of the peptide hormone producing by the which cell? That is your D cell or the delta cell. Okay, so these are small physiological questions from the stomach. Okay, so what the H. pylori do when they enters into the stomach, they decrease the peptide hormone somatostatin, which is produced by the D cell. Okay, and what is the delta cell will do? The D cell, its main is it inhibits the G cell, that is inhibits the gastrin cell secretion. It inhibits the pancreatic and intestinal secretion and regulates the insulin and glucagon secretion. Okay, and suppose if it decreases the D cell, if decreases the somatostatin cell, then what it will happen? There is an increase of the G cell. Okay, so there is an increase of the gastrin. So more gastrin means more acidic. Okay, the more pH. So when there is an increased gastrin means increased acid. When there is an excessive acid, though stomach is acidic in nature, but it is about 1 to 2. Okay, if it is too much, increases anything too much, which resulting into the gastric metaplasia, and there is an ulceration. So in this way, basically the H. pylori resulting into the ulcer formation, and most common site will be the duodenum. Okay, so yeah, this is the about your H. pylori test. Yeah. Hmm. So rapid urease test is the gold standard diagnosis for the H. pylori bacteria. Okay, so these are things. What are the tests? The most common. After that is your
Ma'am,
rapid
previous slide. Just
test.
one second.
Sorry,
Previous slide.
previous
Previous
slide.
slide.
Yeah. This one.
ये इसके पहला वाला.
इसके पहले वाला, this one. So this is
हाँ मैम.
basically from the physiology. Okay. So ये आपको physiology में भी मिल जाएगा. So just to make you understand so that you won't forget what is the basic pathology, how the
हाँ मैम.
gastric ulcer takes place. Okay, अभी जाए next में. Yeah.
हाँ.
So ये भी important है. What are the tests done for the H. pylori bacteria? ये आप याद रखना. Urea breath test. This is a method of the choice but should be performed after the treatment. ठीक है. So यहाँ पर it detects labeled of the CO2 after ingestion of the urea. Stool antigen test detects the H. pylori is present or not. Endoscopy, okay, and the serology. But the most gold standard is your rapid urease test. Okay, so let's move to the another part. Okay, and one thing is wanted to clear that H. pylori usually produce your adenocarcinoma of the stomach. Okay, yes. Okay, now come to the next part about the difference between the gastric ulcer and the duodenal ulcer. ठीक है, तो ये difference आप लोग याद रखना. Okay, so usually suppose if this is the stomach, okay, one is your gastric ulcer and usually one is the duodenal part, that is in the first part of the duodenum. Okay, so in common site for the gastric ulcer is the lesser curvature of the stomach. Okay, whereas the duodenal ulcer in the first part of the duodenum. Age group 40 to 60 years. Here the age group will be 20 to 40 years. In gastric ulcer, what is the main problem? The problem is with there is a mucosal protections. Now suppose, okay, let me show you here. Suppose this is an stomach, okay, and here are lining of the stomach, okay, the lining of the stomach, okay, that is a mucosal layer, okay. If this mucosal protection is damaged, so this is the main reason for the gastric ulcer, usually due to the non-steroidal anti-inflammatory drugs if the person is suffering from the acidity for a prolonged period of the time. Okay, whereas in case of duodenal ulcer, it is mostly due to the increase of the acid and pepsin secretion. Why? Because due to the H. pylori, they decreases the amount of the somatostatin, and then there is an increase of the acid due to the increase of the gastrin level of the in the body. Okay, so this is the main cause. Pain is important. Epigastric pain increases with the food, so the patient avoid eating and there is a weight loss. Whereas in duodenal ulcer, there is an epigastric pain which is relieved by the food. So, so patient eat more and there is a weight gain. Okay, so this is important. Gastric ulcer, the pain usually after the meals, shortly after the meals, and ulcer 2 to 3 hours after the meal, because at the time when the stomach is empty, the patient may wake up at the night also. Okay, so night pain is very common in the duodenal ulcer. H. pylori association in 70% of the cases in GU and 90 to 100% of the cases in duodenal ulcer. Gastric acid level is increased in DU, but it is normal or decreased in the gastric ulcer. Gastric ulcer, they have chance to become malignant and they are almost never malignant in nature. Okay. Vomiting is common. Here the vomiting is rare. Here in duodenal ulcer, melena is more common, but here hematemesis is more common. Okay. Effects of antacid, they release little, they release the pain quickly. Histology, there is an chronic gastritis because there is a mucosal protection decreases, so there is an mucosal atrophy. And there is a Börner glands hypertrophy due to the acid stimulation. So this is very important. Okay. इसके अलावा another thing is that most common complications for the gastric ulcer, the most common complication, I think, yes, it's not there. So most common complication for the gastric ulcer is perforation. Okay, ये लिख लेना. And here the most common complication for the duodenal ulcer is bleeding. Okay, and bleeding is most commonly which artery? ये भी पूछा जा सकता है from the gastroduodenal artery. Okay, and which artery is mostly involved? That is your gastroduodenal artery. Okay. So there is another complications. For example, here you will see a hourglass stomach, or teapot stomach. Okay, these are the some of the complications. Whereas here the most common will be the gastric outlet obstructions. Okay, gastric outlet obstruction due to the pyloric stenosis, because mostly the obstruction ulcer into the first part of the duodenum. If there is an hypertrophy, there is an obstructions in the first part or in the pyloric antrum. So here the most common is a gastric outlet obstruction. ठीक है? ओके, तो ये आप ये कर लो, लिख लो. Next thing we will do the what is the modified Johnson classification for the gastric ulcer. Okay, so these are the modified Johnson classification of the gastric ulcer.
मैम पिछले बार थोड़ा सा लिखना बाकी रह गया.
ये वाला.
एक.
Okay. हो गया और कुछ या बेरियम
मैम गैस्ट्रोड्यूडेनल आर्टरी के नीचे क्या लिखा हुआ है वो?
Gastric outlet obstruction, this is one of the common complications for the duodenal ulcer. Okay, इसका common complication होगा gastric ulcer का most commonly complication is perforation. इसका most common complication is bleeding. Other complication is a gastric outlet obstruction. The bleeding is mostly from the which artery? Gastroduodenal artery. ये सब MCQ pointers हैं, ठीक है? And these are some of the complications of the gastric ulcer. That is your hourglass stomach. Okay, there is an structure of the gastric mucosa, and also there is a teapot stomach. Okay, so shall I move to the next slide?
Yes, ma'am.
Okay, so let's move it here. So what are the modified Johnson classification of the gastric ulcer? So type 1, type 2, type 3, ठीक है, ये diagram याद रखना. So in case of the type 1, what we will see that usually this is in lesser curvature of the stomach near the insuseria angularis. Okay, so type 1 usually in the lesser curvature of the stomach near the insuseria angularis. This is the most common type, okay, in case of gastric ulcer, but the ulcer has been taken place. Type 2, okay, that is in the stomach, lesser curvature and some part in the duodenum. It is combined with the gastric and the duodenal. Type 3 is in the pre-pyloric, so here the pyloric antrum, okay, and type 4 is in the juxtoesophageal junctions near the gastroesophageal junctions, and type of 5 it can be anywhere because it is due to the NSAID, non-steroidal anti-inflammatory drugs. So type 1, type 2, type 3, type 4, type 5 में से सबसे common जो है, which is your the most common is your type 1. Okay, so these are the modified Johnson classification in gastric ulcer. Okay, not the duodenal one, the gastric ulcer. So now come to the difference between the benign gastric ulcer and the malignant gastric ulcer. हमें पता है कि duodenal ulcer have less chance to become malignant. Okay, but the gastric ulcer, they have 100% chances to become malignant. So these are the some of the differentiation. So ये जो part है, this is about your benign one, and this is your malignant. So mucosal fold will be converging fold. Here the mucosal fold is facing mucosal fold. Okay. Most of the cases, site will be in the lesser curvature and this will be in the greater curvature. So ये है malignant gastric ulcer and this is your benign gastric ulcer. Margin is regular. Here the margin is irregular. Okay. Floor, the granulation tissue in the floor, and here the necrotic slug in the floor. Okay, so ये आप याद रखना. Size and extent small, deep up to the muscle layer, they are large and deep. Okay, so ये diagram याद रखो तो आपको easy होगा इसको याद रखने के लिए. Okay, okay. So these are the some of the differentiation between the gastric and the benign and malignant gastric ulcers. Okay, so what are the complications of the peptic ulcer? Similarly,
Ma'am,
already
previous slide, please.
okay. जैसे कि यहाँ पर surrounding area you will see that there is a nodules, ulcer and the irregular, even the margins is also irregular and everted edges. So these are in the histopathology you will find in malignant gastric ulcer. Okay, other than thing or kuch. So they are difficult to heal. They have a necrotic base. There will be no peristalsis. Okay, there will be no peristalsis. Okay, so now come to the next slide, which is about what are the complications. Already बता दिया है, bleeding, Most common complication in the duodenal ulcer, perforation, most common in the gastric ulcer. Gastric outlet obstruction is rare. It is usually seen in the duodenal, mostly in the duodenal ulcer due to pyloric stenosis. Okay, and non-healing, they are very difficult to heal. Okay, suppose आपके पास अगर कोई patient आता है, if he is suffering from acidity, gastroesophageal reflux disorder, they are is easy to treat. But if a patient is suffering from like gastritis, if there is an already gastric ulcer, they will वो आपको दिमाग खा लेंगे एक्चुअली, बिकॉज हाँ मैडम ठीक नहीं हो रहा है, कब तक होगा, बिकॉज इट इज गोइंग टू टेक टाइम. ओके, बिकॉज वेन एवर दे ईट एनीथिंग they are not able to digest because of the formation of the ulcer. अब जब भी वो खाते हैं, there is an increase of acid secretion just to digest that proteins and the fat. So there is some, the healing will be delayed if the ulcer has already been formed. Okay, but healing is more easy in if the person is suffering from only the reflux disorder. Okay, so this is the thing. Okay, now come to the next part about your gastric outlet obstruction. Okay, so most common cause, if they ask you what is the most common cause for the gastric outlet obstruction, the answer will be carcinoma of the stomach. ठीक है, CA of the stomach. So most common site is in the where? In the first part of the duodenum. This is the most common site. Okay, and more common, it is associated with the duodenal ulcer and also about type 3 type of pre-pyloric ulcer. Okay, so most common in the duodenal ulcer and the type 3 gastric ulcer. Okay, which is rare, but most commonly in the duodenal ulcer and also in the carcinoma of the stomach.
मैम
Okay,
एक
so
बार फिर
what
से
are the
रिपीट कीजिएगा मैम.
clinical symptoms you will find in the gastric outlet obstructions? Number one, now suppose this is stomach and if there is an obstruction in this pyloric part, the food which is entering here, it cannot enter into up to the from the duodenum, it cannot enter into the intestinum. Okay, though, so what are the symptoms? There will be early satiety. ठीक है, मैं एक रोटी खाता हूँ, आधी रोटी खाता हूँ और फिर मेरा पेट भरा भरा लगता है. दैट इज इट. यूजुअली पेशेंट विल कम टू यू, okay, while telling their complaint. Okay, so easy satiety or the early satiety and there is an bloating. Okay, there is an bloating. Why? Because there is a formation of the ulcer, the gastrin is not the pepsin which is all present in here, अगर ठीक से digest नहीं होगा, so there all will be, there is an bloating is one of the symptom. Okay, other than this, there is an anorexia and the most common is the epigastric pain also. Epigastric pain. If the nutrient cannot absorb, then there will be a weight loss. Okay, so these are the some of the clinical features of the gastric outlet obstructions.
मैम
Now come to
इससे
the
पहले वाला स्लाइड थोड़ा सा एक बार बताइएगा ना,
ये
वो
वाला,
ये वाला लास्ट पोर्शन वाला सुनाए, इससे पहले वाला. हाँ
this one.
हाँ हाँ, ये दिस वाला
Okay,
लास्ट
so
पोर्शन.
here if the question asks what is the most common cause for the gastric outlet obstruction, okay, suppose this is stomach and this is an outlet. Okay, यहाँ से pyloric sphincter है, this is your cardiac sphincter, not pyloric, and this is your pyloric sphincter. Okay, so usually gastric outlet obstruction occur in this part of the duodenum. Okay, that is in the pylorus and the duodenum के बीच में, that is in the first part of the duodenum. Okay, so most common site is in the first part of the duodenum. The most common cause will be carcinoma of the stomach and the followed by the duodenal ulcer, and then type 3 gastric ulcer which is pre-pyloric. If you see this image, this is a pre-pyloric part. This also result in the gastric outlet obstruction but in rare cases. Okay, and yeah, this is the only thing. अभी समझ में आया?
यस.
Okay, Now let's move into the risk factor for the carcinoma of the stomach. Okay. Okay. So if you see the smoking and meats, okay, smoked meat, the coals, everything, and these are the some of the risk factor. For example, H. pylori infection is the strongest risk factor. Epstein-Barr virus. These are the risk factor for the CA stomach. Dietary factors may smoked meat, pickled, salted food, high nitrates food, low intake of fruits and the vegetables, high salt intake, some environmental factors such as pollutions, lower socioeconomic status, chronic alcohol intake, smoking and drinking water with nitrate. Okay, that is another thing. One is in the blood group A. Okay, so is there? Yeah. So there is another thing, for example, chronic atrophic gastritis, pernicious anemia, which is resulting due to the vitamin B12 deficiency causes. And if there is a family history of gastric ulcer, hereditary diffuse gastric cancer. Okay, so these are some of the risk factor for the CA stomach. And एक है a blood group in genetic factors में there is in genetic factors में और एक है that is your blood group A, they have more chances to develop a stomach cancer. Okay, remember here, if it is written chronic alcohol intake, but in some book it is also written that alcohol is not a risk factor for the CA stomach. In some book it is written as alcohol is not a risk factor. ठीक है? तो अभी now it has been found out that alcohol is a risk factor for this gastric carcinoma. Okay. So so what are the clinical features and what are the incidence of the and where are the most commonly site where the carcinoma occur? Okay, so if I have, okay, let's see the CA stomach. Okay. So these are the tumor marker. ठीक है, CEA C19/9, CA125, yeah, but CA125 mostly used for the ovarian carcinoma, but most commonly CA19 and 9 and CEE, they are the most common tumor marker for the carcinoma of the stomach. These are the most common metastasis: liver, followed by the lung, and then the bone. So liver followed by the lung and then the bone. Okay, so these are MCQs questions. If they ask what is the most common complaint of the CA stomach, the most common symptom will be abdominal pain. Okay, the most common symptom of the carcinoma of the stomach is abdominal pain. Okay, and then if there is a cancer, always there is a weight loss. Remember, this type of the pain is a constant pain. There is no radiation of the pain, and this pain is unrelieved by the food ingestion. Okay. So other than this, if the cancer has spread, then there may be ascites. Okay, then there may be ascites. You will find some palpable mass around this umbilicus. Okay, so this is known as your Sister Mary Joseph nodules. It is notated as a nodule just around the umbilicus associated with the advanced malignancy of the stomach. जरूरी नहीं है कि सिर्फ carcinoma of the stomach में हो, any type of the abdominal malignancy, we can see this Sister Mary Joseph nodules. Okay, varicose node, there is an also a palpable mass in the supraclavicular region. Okay, in the supraclavicular region, this is known as your varicose node, a mass in the supraclavicular region. Okay, okay, there is another thing that is Irish nodes. If there is a large lymph node in the axilla, okay, in the left, especially in the left axilla, Okay, if there is an enlarged lymph node, especially in the left axilla, this is called as an Irish nodes. Okay, positive Trousseau sign, that is thrombophlebitis and acanthosis nigricans. Okay, and then if there is an peritoneal metastasis on rectal examination, if there is an inflammation of the lymph node, then there will be a implantation of the carcinoma in the rectum. Then rectal shelf of the bloomer is also there. It is known as the bloomer shelf. Okay, so bloomer shelf, Warcos nodes, sister Mary Joseph nodules, left axilla में Irish nodes. These are that is your that usually seen in the advanced malignancy, not only in the carcinoma of the stomach but in any type of the abdominal malignancy. Okay, so this is also called as a bloomer shelf. Hmm. So best method to diagnose this case, endoscopy, endoscopy with the biopsy. So endoscopy with the biopsy. This is the best method to diagnose the gastric cancer. To know the staging of the cancer, investigation of the choice for the to know the cancer in which stage, we have to go with the endoscopic ultrasound. And if the person, if suppose if there isn't a large tumor and the surgeon want to operate that, for that the best investigation for the pre-operative stage will be CT scan. So best investigation for pre-operative staging is a CT scan. Okay, so yeah. So what is the prognosis factor? Prognosis factor is about lymph node status, okay, and the depth of invasion of the ulcer, depth of invasion. So this is the prognostic factor. More than the tumor marker, the prognostic factor will be the depth of invasion and the lymph node status. Okay. So this is all about your carcinoma of the stomach. We will go very slowly. We're not going very fast. Okay. Okay, now let's move to the gastrointestinal tumor. Hmm. So if you see this, gastrointestinal stromal tumor is the type of the tumor that occur in GIT tract. Okay. So GIT tract शुरू होता है from the mouth to that of the rectum up to the anal canal, but it's most commonly in the stomach or the small intestine, and which cells, especially in the interstitial cells of the Schedul's. Okay. So इतना याद रखना, the gastrointestinal tumors, which cell is commonly affected? Your answer will be interstitial cells of Schedule, the pacemaker of the cell that controls the peristalsis. ये भी पूछा जा सकता है, what is the pacemaker of the GIT? Okay, the pacemaker of the GIT is interstitial cells of Schedule, which is present in the small intestine. Okay, so this is called your gastrointestinal tumor. Okay, and so most commonly primary site of the tumor will be the stomach, then the small intestine, then the small intestine, okay, followed by the colorectum, followed by the colorectum, and then the esophagus. Okay, so most commonly stomach, then the small intestine in 70% of the cases in the stomach, then the small intestine, then the colorectum, and then the esophagus. Okay, and arises from the which cell? Interstitial cells of the Kagel. Okay, so usually they are in the which layer of the cell? In the muscularis mucosae. Okay, so in this like layer of the like lining, in this lining of the stomach, usually you will see the interstitial cells of Kagel. So this can be one of the MCQ आ सकता है. Okay, in which part? That is in the muscularis mucosae, are most likely to originate from the cells of the Kagel. Okay. Now, what is the tumor marker? Okay. What is the tumor marker for the gastrointestinal cell? So the tumor marker will be CKIT CD177 and DOG1 positive. थोड़ा याद रख लेना. ठीक है. So this one is important. The marker क्या हो सकता है? And most common presentation will be the most common presentation or the manifestation will be the gastrointestinal bleeding and the pain. इसमें तो पूछा जाता है which is okay, so these are the most common site, and obviously these are some clinical features. I told you abdominal pain, GIT bleeding, and other symptoms will be fatigue, anemia from the chronic bleeding, and EV satiety if there is an obstruction, okay, due to the tumor. So this is important. What is keratinoid and where it is seen? It is seen in the your gastrointestinal tumor. So it is associated with the ganglionoma, especially if this ganglionoma is present in the lung, it is known as chondroma. If it is in the stomach, in the GIT stomach cell, if it is in the adrenal ganglion, okay, frecocytoma or the paraganglioneuma, okay, or the multiple focal gastrointestinal tumor. So this three together, that is affection of the lung, tumors in the lung, in the stomach, and the adrenal, this association is known as your Carinese triad. Okay, usually seen in the gastrointestinal stomach tumor. The investigation of the choice is your CT scan, and the gold standard will be the PET scan to know the full where the tumors are there in all over the body, especially the other associated tumor. Okay, so these are all about your gastrointestinal tumor. ठीक है. Okay, let's move to the ये बहुत small notes हैं. What do you mean by the Buzzards? It's a tightly packed collection of the digested or undigested material that most commonly occurs in the stomach. तो कुछ भी हो सकता है, बाल भी हो सकता है, कुछ मेडिसिन भी हो सकते हैं, ओके, कुछ भी हो सकता है, एंड सम हेयर्स, ड्रग्स, vegetables, anything. All together, if they are collected in some part of the intestine, these are called as your Buzzards. Okay. So most commonly are the phytobazar. This is most commonly found by the vegetable and the plant fibers. Seen after post-gastrectomy, vagotomy due to the poor gastric motility. Okay, so most common अगर पूछा जाए, the most common will be your phytobazar. Most commonly seen after the surgery of the stomach. The trichobazar means if there is an hair, especially the hair of the girls, of the women, okay. Sometimes who often deny they are not eating, कुछ कुछ होते हैं ना जो बाल भी खाते हैं, okay, or they are suffering from the trichotillomania. Usually there you have seen this type of the hair in the intestine, especially in the small intestine. This is trichobazar. Pharmacobazar means same thing, if this medication that clumps together. Lactobazar formed from the milk curd, usually seen in the infant. Okay, but in सब में से सबसे common जो होगा that is your phytobazar. Okay, so this is only this much. Okay. Let's move to the Next part, yeah, about the gastric volvulus. Anything, anybody have any problem from the first slide? So I
मैम
can,
पिछले वाला
हाँ,
स्लाइड बहुत फास्ट जा रहा है, कुछ नहीं लिख नहीं पा रहे हैं।
ठीक है,
ये
ये अभी लिख लो। ठीक है, आप लोग कैमरा भी है ना आपके पास मोबाइल पे, आप वो मतलब खींच भी सकते हो। एक एक करके लिखने में बहुत डिफिकल्ट हो जाता है, मतलब इट इज जस्ट टाइम टेकिंग। तो इफ यू हैव मोबाइल और लाइक कैमरा है, तो किसी और मोबाइल से कैमरा में यू कैन क्लिक दिस थिंग, अब बाद में फिर लिख लेना नोट्स बना के। ठीक है, सो आई थिंक दिस इज मोर फीसिबल। ठीक है, लेट्स शैल आई मूव।
ओके मैम।
ये वाला लिख लो, व्हाट इज ट्राइकोबेजो। हम्म, दिस वन। उसके बाद यू विल कम टू द गैस्ट्रिक वॉल्वुलस। You take your time, you write it down. चले, so let's come to the about gastric volvulus. Okay, so basically there are the two types. If you've seen in the diagram, okay, one, if it is in longitudinal and this is your the horizontal. Okay, if the torsion, ठीक है, if the torsion or the twisting of the stomach occurs in the longitudinal axis. Okay, so this is longitudinal axis. Basically, what is gastric volvulus? It is the volvulus of the stomach that is twisting of all the part of the stomach by more than 180 degree. As a result, if there is an obstruction of the flow of this blood flows, variable loss of the blood supply, and sometimes if there is a loss of the blood supply, which resulting into the tissue death. Usually gastric volvulus are two types. If it is in the long axis, okay, if the torsion or twisting in the long axis, this is called your organoaxial. Okay, organoaxial. AXIAL, axial. And if it is in the vertical axis, okay, along the vertical axis, if the twisting of the stomach along the vertical axis, then this is called your mesenteroaxial. तो ये याद रखना, what is mesenteroaxial and what is organoaxial, ये confuse होता है. Okay, one is longitudinal, okay, and another is your vertical. ठीक है, so what is the difference between these two? Now you have to write it down. So one is primary gastric volvulus and other is your secondary gastric volvulus. तो इन्होंने divide किया है primary and secondary. It's the same thing about your if the primary gastric volvulus, it is usually ये sorry, this is organo rotation along the long axis is organo, sorry, this is organoaxial. सही लिखा था. Okay. So, primary gastric volvulus, rotation of the stomach without any underlying defect, whereas in the secondary, if there is some defect in the organ, this is resulting into the secondary gastric volvulus. For example, diaphragmatic rotation of the stomach due to some underlying diaphragmatic or adjacent organ abnormality. Most commonly क्या है? Diaphragmatic hernia. Okay, the most common is diaphragmatic hernia. Okay, yeah, the usually due to the laxity or the absence of the gastric ligament, we have ligaments in the stomach, so there may be an absence of the gastric and it is due to some secondary condition. The most commonly I told you about the diaphragmatic hernia. Age group most commonly seen in the children and the young adult, more commonly in the older adult. Okay, type of the volvulus, rotation along the long axis, and that is your cardiac to pylorus. So cardiac to the pylorus, so it is your organoaxial. This is mesenteroaxial. Congenital defect, and this is due to the diaphragmatic defect. Association, associated with isolated gastric problem, associated with some thoraco-abdominal defect. Okay, so just write it down, the difference between the primary and the gastric volvulus. Obviously, volvulus, so the most clinical common features will be what? Pain. Okay? So there is an feature is pain plus. So if there is an twisting of the stomach, you cannot pass the nasogastric tube. Okay, so there is an inability to vomit plus inability to pass a nasogastric tube. Inability to pass. This is in the next actually slide. ये है, तो I'm just nasogastric tube. We just finished this one. What you will see, this is called as your Broca triad. It consists of severe epigastric pain without vomiting and the inability to pass a nasogastric tube. This is known as your Broca triad, seen in where? Seen in the gastric volvulus. Just write it down. Then we will move to the next slide. अगर आपको ये लिखना हो गया हो तो okay. So this is one is seen in the more than 70% of the cases. Sometimes there will be severe pain at the top of the left shoulder, and there may be some internal bleeding which aided the diaphragm upon the respiration. इतना याद रखने की जरूरत नहीं है. ये triad याद रखना. Epigastric pain without vomiting, inability to vomit, and inability to pass the nasogastric tube. Okay. So, X-ray, what you will see in the X-ray, gas-filled viscous in the chest and the upper abdomen. In the X-ray of the abdomen, what we will see, gas-filled viscous. Okay, so in abdomen, in the stomach, there is an full of gases. Okay, in the organs. This is in the gastric volvulus. Okay. Now, another one which is very important topic है. ये लिखना हो गया आप लोगों का? Just type or just can say in the
gas filled viscous.
gastric volvulus है. अच्छा, gas filled viscous है. मतलब organs में गैस का बन जाना, ठीक है? गैस फिल हो जाता है ना, पेट में गैस फिल होता है, तो एक्सरे में आपको ये दिखेगा कि ऑर्गन्स में देयर इज एन फिलिंग ऑफ द गैसेस है, स्पेशली इन द अपर एब्डोमेन और इन द चेस्ट. ठीक है? And to diagnose this, you have to go with the like barium meal, bar meal X-ray or the endoscopy, whatever. ठीक है? So let's start with the next part. That is IHPS. The full form is your infantile hypertrophic pyloric stenosis. This is infantile hypertrophic pyloric stenosis. So if there is an hyperplasia or hypertrophy of the pyloric muscles resulting into the gastric outlet obstruction. Okay, and usually infantile है, तो obviously it is seen in the infant. Okay, and in the barium study you will see a string sign. ये याद रखना. If the pyloric canal become narrow and elongated in the barium stud Barmil X-ray, you will see a string sign. So this is one of the MCQ seen in where? Seen in infantile hypertrophic pyloric stenosis. Okay. Now what happened to actually? So usually seen in the infant or the condition most commonly between the age of 2 to 8 weeks of the life. The infant, she or he is suffering from persistent projectile frequent episode of the non-bilious vomiting. So if it is the stomach and if there is an obstruction is here, so whatever food enters here, it just comes out. Okay, just like gastric outlet obstruction. Okay, so there will be a non-bilious vomiting 30 to 60 minutes after the feeding. Later, the patient will suffer from the weight loss as the food content does not enter into the stomach. There is a persistent hunger. There may be jaundice because the enzymes, that is hepatic glucuronidase, it is not growth properly because it is infant stage. So that was resulting into the jaundice. So these are the clinical feature of a congenital hypertrophic pyloric stenosis. Usually it is seen in the first born male. Okay, first born male. So अगर मेल एंड फीमेल रेशियो में ज्यादा है तो 4:1 रेशियो. मेल आर मोर लाइकली टू बी सफर देन दैट ऑफ द female. So for example, infant is normal at birth, but the problem starts after 3 to 6 week or the 2 to 8 week. Okay, so there is an vomiting of the food or the nutrition, there is an electrolyte imbalance, so there is an hypochloremia, hypokalemia. Okay, so there is an hypokalemia with metabolic alkalosis. So this is one of the important, आपको पूछा जाता है कि what is the typical electrolyte abnormality in case of infantile hypertrophic pyloric stenosis. So there is hypochloremia, there is hypokalemia with metabolic alkalosis, renal compensation. What happened? The HCO3, that is bicarbonate, it comes out. The body wants to retain the sodium and the HCO3 it comes out, which resulting into the paradoxical aciduria. So ये बहुत बार पूछा गया है, what is the typical electrolyte abnormality in the infantile hypertrophic pyloric stenosis? Hypochloremia, hypokalemia, metabolic alkalosis and paradoxical aciduria. इसको आप लोग याद रखना. ठीक है? So diagnosis, always you will see a olive shaped mass. Okay, so if you see this diagram, in the barium shallow, this is string sign, or it is also known as your mushroom sign. Okay, mushroom sign now. Okay, and sometimes if there is an gastric outlet obstruction, like its size increases, then you will see some pyloric tumor on palpation. Okay, so on diagnosis, that is on palpation of the pyloric tumor or the olive, especially in the epigastric area. So on diagnosis, if you palpate the epigastric level, you will find an palpatable tumor, or it is known as olive. Okay, usually it is a pathognomic sign for the hypertrophic pyloric stenosis. So if it's say what is the pathognomic sign, what is a pathognomic sign for hypertrophic pyloric stenosis, your answer will be a palpable tumor in the pyloric antrum. Okay, or or something olive type of growth in the epigastric region. So this is all about your
मैम
congenital
वो एक बार
hypertrophic
लाइन,
pyloric stenosis.
palpable of the pyloric tumor और
ऑलिव, दिस इज वो बेसिकली इसका दूसरा मेडिकल टर्म में बोलते हैं ऑलिव. ऑलिव देखा है ना, ऑलिव का जो फल होता है ना, ऑलिव. if you search in the Google, you can find if that olive fruits कैसे देखने में होता है. So it is the same thing, that type of the growth you will find on palpation of the abdomen of that infant baby. Okay, so that is your olive type of the growth or some type of the tumor. If you palpate the abdomen, you will find that growth, especially in the epigastric area. Okay, so yeah, this is all about your hypertrophic pyloric stenosis. इसमें से important है electrolyte imbalance, male are usually, तो ये सब important points आप लोग याद रखो. String sign is also positive in Crohn's disease, हम लोग बाद में आएंगे. Mushroom sign is seen in this like congenital hypertrophic pyloric stenosis. Okay,
मैम ये
now
साइन वगैरह क्या सिर्फ बच्चों में होगा कि सब में होगा, मतलब
नहीं नहीं,
हाइपरट्रोफिक?
ये इन्फेंटाइल हाइपोट्रोफिक पाइलोरिक है ना, तो ये पर्टिकुलरली इनमें ही पाया जाएगा. ठीक है, अदरवाइज यू विल सी इन द गैस्ट्रिक आउटलेट ऑब्स्ट्रक्शन में बोलता करके. सो इट इज ओनली सीन इन द इन्फेंटाइल हाइपोट्रोफिक पाइलोरिक स्टेनोसिस, स्पेशली इन दिस इन्फेंट एज. ओके ओके, चलो लेट्स मूव टू द नेक्स्ट पार्ट. सो कम टू द स्मॉल बाउल ऑब्स्ट्रक्शन. 445. So this is all about stomach. और we'll next move to the small bowel obstruction. में सबसे पहले जो आएगा intestinal obstruction में, या the most common cause for the small bowel obstruction. Okay, the most will be the adhesion, the most common cause. This is the most common cause for the small bowel or the small intestine. Okay, ये क्वेश्चन पूछा जा सकता है. Okay, so first is adhesion. Then there will be some malignant tumor, the carcinoma. Okay, उसके बाद inflammation, and then there is some hernia. So these are the some of the common causes for the small bowel obstructions, and these are another causes. Suppose foreign material. Okay, these are the other. Now what happened actually in SBO, for example, suppose this is your small intestine. ठीक है, ये normal intestine है. Okay, and now there is some obstruction in the, ओके कोई ट्यूमर फॉर्म हो गया, या तो एडिशन हो गया. ठीक है, एनीथिंग. सो देयर इज इन सम ऑब्स्ट्रक्शन इन द स्मॉल इंटेस्टाइन. सो व्हाट आवर बॉडी विल डू, first they will increase the peristaltic movement to propel this content out from the body. So first there will be an increased peristaltic movement. So if there is an increased peristaltic movement, the patient may complain of pain with diarrhea. ठीक है, increased motility, contraction and relaxation ज़्यादा increased होगा. Okay, as a result, the first symptoms of the small bowel obstruction will be colicky abdominal pain. Okay, will be the colicky abdominal pain. Now sometimes this obstruction is also depend, अगर मतलब sign will also depend if it is in the proximal part or if there is an obstruction in the distal part. अगर सामने की तरफ हो और एकदम नीचे की तरफ हो obstruction, उसके the obstruction also decide what type of the complaint that patient will develop. Okay, but whatever the where is the obstruction develop, the most common symptoms will be the colicky abdominal pain. Okay, the cardinal sign will be, the first symptom will be the colicky abdominal pain, both above and below the point of the obstruction. And then first along with this diarrhea, बार बार peristaltic movement होगा, बार बार दर्द होगा, and then person will go to the stool, small amount of the stool pass होगा, mucus होगा, नहीं होगा. Okay, and that stool is, that is incomplete filling sensation. Okay, and this is the first symptoms. After that, what happened when there is an excessive peristaltic movement in the intestine? In the later part, the intestine get fatigue. ठीक है, so when there is an intestine get fatigue, that means peristalsis decreases. So धीरे धीरे क्या होगा, colic abdominal pain कम हो जाएगा. Now the person suffer from the abdominal bloating plus obstipation. Okay, that is even failure to pass the fetus flatus. Okay, so there may be the second sign will be the constipation. तो पहले diarrhea and then the constipation. Okay, suppose a patient come to you with a clinic of only with the constipation. मुझे पहले तो थोड़ा इस तरह होता था, क्लियर नहीं होता था, या मुझे डायरिया हुआ था तो मैंने दवाई ले लिया. ओके, नाउ आई एम सफरिंग फ्रॉम दिस कॉन्स्टिपेशन. इस तरह से भी पेशेंट आ सकते हैं. ठीक है. सो फर्स्ट सिम्टम्स विल बी पेन, diarrhea, then the intestinal peristaltic movement decreases, the intestine become fatigued. Now the patient suffer from the constipation, and later it resulting into the obstipation. Okay, if I write it here, then okay. So then the later it will be the obstipation. Obstipation means failure to pass a fetus, or also the flatus. Feces and flatus, they failure to the pass. Okay. Obviously, along with this, there is a nausea and the vomiting and the abdominal distension. Now, if there isn't some strangulation, then the fever is also one of the characteristic features of the small bowel obstruction. If fever is there, that means there is a strangulation already occurred. Okay, so strangulation. तो पहले क्या होगा, there is an peristaltic movement is very high, so you can hear the bowel sound. ठीक है, especially in the thin patient, even you can see that movement of the peristaltic movement of the stomach if the patient is very thin. And also you can, if you put your stethoscope, and even without the stethoscope you can hear that gurgling, rumbling sound, that is purpling, that is peristaltic sound of the intestine. Later what, it usually decreases, and now the person is suffering from the constipation. ठीक है. So what you will see in the x-ray of the small bowel obstruction, you will see that there will be multiple air fluid level. Okay, in the x-ray you will see multiple air fluid level, which usually like a stepwise pattern. Okay, multiple air fluid level, just usually like a step like pattern. Okay. So this is in the x-ray. Also in the x-ray you will find some dilated loop of the intestine. Okay, and you will find some dilated loop. ठीक है. तो सपोज ऑब्स्ट्रक्शन हुआ यहाँ पर. ओके, पेरिस्टाल्टिक मूवमेंट, तो एक जगह some the dilated because of the fluid space increases, and then again there is a short word of the spaces इस तरह से. So you will see some dilated loop of the small intestine, especially at the level of the obstruction. Okay, and but the most commonly you will see a multiple air fluid level, and it will be a step like pattern. So this is all about your small bowel obstructions, and they are also malignancy is also one of the cause. If there is a tumor and the polyp in the intestine, that resulting onto the small bowel obstruction. Okay.
मैम वाई फ्लूइड, एयर तो समझ आ रहा है पर फ्लूइड.
मल्टीपल एयर फ्लूइड लेवल, अभी क्या है ना, अभी सपोज ये इंटेस्टाइन है. ठीक है, यहाँ पर यू हैव इलेक्ट्रोलाइट. ठीक है, वी हैव न्यूट्रिशन वॉट एवर वी ईट. ठीक है. सो अभी सब अगर यहाँ पर डाइजेशन नहीं होता है, अगर सपोज प्रोपेल नहीं, मतलब अगर सपोज इफ देयर इज एन ऑब्स्ट्रक्शन, okay, and there is a peristaltic movement. Okay, if it is there is no movement, the later part when the peristaltic has sluggish in nature, so यहाँ का space increased हो जाता है. Okay, and what an intestine become very lax, and whatever the content which is present, the mucosal content which is present in the intestine, it enters into the outer space. This you will see in the dilated loop, which looks like an air fluid level. ठीक है, क्योंकि फ्लूइड भी ऑल द इलेक्ट्रोलाइट कंटेंट, जो इलेक्ट्रोलाइट है ना बॉडी में, magnesium, potassium, that will enters into the your third space. उसको फॉर एग्जाम्पल दिस इज इंटेस्टाइन, ठीक है। तो अगर इंटेस्टाइन बहुत लैक्स हो जाता है, बहुत पोरस हो जाता है, तो यहाँ पर भी फ्लूइड it will comes down and it resulting into the third space, okay, which you will see it is seen as an air fluid level. यही है what I think है, ठीक है, समझ में आया? And
Yes, ma'am.
afterwards, if there is an the patient suffer from the dehydration, obviously the fluid cannot absorb into the body, it produces third space in the intestine, so that means the person suffer from this dehydration, okay, or the hypovolemia. Okay, now let's move to the next part about the paralytic ileus. Same thing, complete absence or the severe reduction of the intestinal peristalsis leading to the failure of the passage of the intestinal content. एक चीज याद रखो, paralytic ileus जो है, it is basically paralysis of the movement, peristaltic movement of the intestine. This is which is not due to any obstructions. So basically small bowel obstruction दो type का होता है, one is mechanical and other is your non-mechanical. Okay, the non-mechanical में paralytic ileus है, but mechanical if there is some obstruction, stone हो गया, कोई polyp हो गया, कोई growth tumor हो गया, ठीक है, even trichobasor, okay, phytobasor, these are also resulting into the mechanical small bowel obstruction. But in paralytic ileus, it is basically the intestine becomes fatigued. As a result, the peristaltic movement does not occur. This is called as paralytic ileus. And this is a basically neuromuscular disorder. Okay, the condition will be the same. The clinical features will be the same. There is an accumulation of the gases, accumulation of the fluid, the distension of the abdomen, vomiting, same feature होगा, but here pain is not colicky in nature, ठीक है। अगर पेन अगर कॉलिकी नेचर है, इट इज यूजुअली सीन इन द मैकेनिकल ऑब्स्ट्रक्शन, ओके। बट यहाँ का जो पेन होगा, इट इज वेरी मच डल एंड डिफ्यूज, इट इज वेरी मच डल एंड डिफ्यूज, नॉट टू मच colicky like that of colocynth and the chamomilla, okay, severe colic and there is हल्का हल्का पेन होता ही रहता है, हर समय होता रहता है, that is steady diffuse a discomfort, a dull type of the pain every time in the abdomen. Okay, so this is only the you can distinguish if it is too much colicky pain, then it can be to the mechanical obstruction. If it is a dull diffuse pain and the patient is not passing stool for so many days, and if you go with the x-ray of the abdomen, you will see that multiple, stepwise pattern of the air fluid level, then it can be reason of a paralytic ileus. Okay. Now, so these are some of the causes. क्या क्या हो सकता है after the laparotomy? If the person is suffering from some electrolyte imbalance due to some drugs, okay, intra-abdominal inflammations, intestinal ischemia, and the systemic sepsis, okay. So obviously there is a minimal or no pain, constipation, no passage of the flatus, and tympanic abdomen or percussion because of the gas filled in the abdomen. Okay, so this is all about your small bowel obstruction. Just give me 5 minutes. Okay, so let's start with the next part of the intersusception. Intersusception means telescoping of the bowel. ठीक है, ये याद रखना. This one. So suppose एक bowel, one part of the intestine, if it is enters into the another part of the intestine. Okay, this is called your intersusception. Okay, so if there is an intersusception, if there is an decrease in the blood flow, so most common complication, there will be formation of the gangrene, necrosis. Okay, so the apex part, where the most there is in construction, the apex part is more prone to gangrene. Apex part is more prone to gangrene. Okay, so this is what is this telescoping bowel? That is when there is an entrance of telescoping on one part of the portion of the intestine into the other. Okay, most commonly seen in the infant. Most commonly seen किन में दिखाई देता है? That is in the infant. Okay, and the most common type will be the ileocolic, especially ileum and the coliac region. The most common type will be, यहाँ पर लिखा है, या in ileocolic है. Okay, so we will come to the letter बाद में. The most common type will be the ileocolic. ये एक क्वेश्चन आ सकता है. Okay, etiology. So basically idiopathic है, but sometimes if the infant is suffering from repeated recurrent upper respiratory tract infections, okay, if there is an if etiology, if I say the, एक minute, if I move it here, yeah, the etiology, for example, recurrent urinary tract, upper respiratory tract infections, okay, upper respiratory tract infections, if there is a recurrent, or if there is a recurrent gastrointestinal infections. Okay, so what happen if there is a recurrent? Sometimes it resulting into the hypertrophic of the Peyer's patches. It is basically idiopathic. Why it has happened, we do not know, and which resulting into this intersusceptions, most commonly into the iliac part. Okay, so in the infant, there is an infant or the child will complain of pain in the abdomen. Okay, if I write it here, yeah, okay, यहाँ पर लिखा नहीं है. So the most clinical feature of will be a pain in the abdomen, and the pain will be colicky in nature. Obviously, there is an obstructions. Okay, the pain will be colicky or the cramping in nature, and इसका pain ना always remember the pain of the colosynth. ठीक है? Okay, so knee chest position get a relief. Same thing. Okay, the pain is colicky in nature, and during the episode of the child cries with the knees drawn up. Okay, and the vomiting is very much consistent. Then vomiting is universal. So vomiting is universal. Okay, there is a passage of the stool, which stools look like a red currant jelly like stool. ठीक है, एलोसॉक्रोटिना का जब हम लोग स्टूल पढ़ते हैं ना, जेली लाइक स्टूल निकल गए. ठीक है, you will same type of the stool you will find in the intersusceptions. Maybe it can be used, allosaprotina can be used in like intersusception cases, maybe or may not be. But if you see the clinical features of the allosaprotina, they have also the same clinical features of the intersusceptions. Okay, red currant jelly like stool. Okay, usually seen in the intersusception. Okay. Okay, now yeah, in ileocolic intersusception, the most common will be the terminal ileum is affected. ठीक है, so that is most commonly is ileocolic. As a result of this, in the right iliac fossa, where the cecum normally lies, because there is no organ, it gets enters into the ileum. So what happened? There is an, it's become empty. Now this is called your dance sign. Okay. Now this is called your empty or sign of a dance. Sign of dance means your feeling of emptiness in the right iliac fossa. अगर पूछा जाए what is dance sign or sign of dance, where it is seen in the interception, and it is meaning of feeling of emptiness in the right iliac fossa. Feeling of emptiness in the right iliac fossa. Okay, and these are the some of the sign in the radiological investigations. For example, target sign in the x-ray. In the x-ray of the abdomen, you will see a target sign or the meniscus sign. So yaad rakhna, theek hai, these some of the sign they can ask you in the MCQs. Target sign or the meniscus sign, no, looks like a target. Okay, and this is a Dognut sign or the target sign. Okay, in the Baria minima, the claw sign, okay, looks like a claw. So claw sign is also seen in the interception, all the, or if you see this like a coil spring, okay, like a coil spring. So this is called as coil spring sign. So these are some of the sign which can seen in the interception. Sorry, cold lag raha hai. Coiled spring sign. COILED, coiled ring sign seen in interception. Claw sign, okay, this is the claw sign, it is also seen in the interception. Okay, so these are some of the MCQ type of notes they can ask you from the interception. Okay, and other thing, hmm. Hmm. And some of the associated other symptoms is your submucosal hemorrhage. Okay, so other associated sign will be submucosal hemorrhage. Okay, HS purpura, submucosal hemorrhage in all over the body, or it is also known as HS purpura. Small purpuric spot in the leg. Okay, so suppose if you go and study the materia medica, how will you diagnose such cases? मतलब कौन सा medicines हो सकता है, right? हम लोग को आता है. So this type of purpura is seen in which type of these medicines. Go through that and read that from various materia medica. Then you will come to understand कि okay, now this medicines can be used in this type of the cases. Okay, submucosal purpural hemorrhage, it is seen in the sulfuric acid, and if you see in sulfuric acid, they are very low form of the diseases you can see. So it can also be seen in this type of the cases. Okay, so let's move into the some of the other thing, which is your small bowel neoplasm. ये याद रखो, most common tumor of the small bowel is stromal tumor, adenoma. Most common tumor of the small bowel in children is lymphoma. Most malignant tumor of the small bowel is adenocarcinoma. ठीक है? This is, yeah. Now, just come to the large bowel obstruction. So large bowel obstruction is again divided into the two types, same as like small bowel obstruction. एक होता है नॉन मैकेनिकल, दूसरा होता है मैकेनिकल. ठीक है, so non mechanical, it is also called as a pseudo obstructions. Pseudo obstruction, and this is the mechanical obstruction. Okay, or the dynamic obstruction. Okay, it is pseudo obstruction or the adynamic obstruction, the non-mechanical obstruction, whereas the mechanical obstruction will be the dynamic and the pseudo. Okay, so the most common, what is the most common cause for the large bowel obstructions? If they ask you the most common cause for the LBO, large bowel obstruction, your answer will be colorectal cancer. The most common cause, symptoms same का same ही होगा थोड़ा बहुत, and the most common cause is your colorectal cancer. Okay, colorectal cancer. Okay, so carcinoma of the rectum, and then the followed by the sigmoid. Okay, so and the third is your the adhesion. The most common mechanical obstruction होगा pseudo obstruction में same है, there is an absence of intestinal contractility. ठीक है, and the what you will the causes for the small bowel obstruction, the same causes will be in the large bowel obstruction, but the most common for the large common cause for the large bowel obstruction is the कोलोरेक्टल कैंसर. इसके अलावा हार्निया हो सकता है, ठीक है, एनी टाइप ऑफ द ट्यूमर इन एनी पार्ट ऑफ द इंटेस्टाइन, ओके, एनीथिंग, बट द कैंसर ऑफ द रेक्टम इज द मोस्ट कॉमन कॉज है. ओके, and abdominal, if you the x-ray will be distended colon. From the CT scan we will diagnose the case, so distended colon. So if there is a rectal cancer, the most common symptom is क्या है? पेनलेस ब्लीडिंग है. ओके, पेनलेस ब्लीडिंग बहुत ज्यादा. यू कैन थिंक ऑफ हेमोरॉइड्स, इतना इतना ब्लीडिंग हो रहा है. मे बी देयर इज सम पॉलिप, and that polyp can be cancerous in nature. If there isn't too much painless bleeding, okay, and if there isn't weight loss, if there is a weight loss and like painless bleeding for a profuse period of the time, and then you will, if you go with the CT scan, then you will diagnose this case, that is a case of some type of the obstruction in the rectum area. Remember, in rectal bleeding is always painless if it is due to the carcinoma of the rectum. Now volvulus, it's the same thing, the gastric volvulus. तो यहाँ पर द मोस्ट कॉमन जो सिग्मॉइड लाइक ट्विस्टिंग होता है, दैट इज द सिग्मॉइड पार्ट ऑफ द सिग्मॉइड कोलोन. ओके, so sigmoid, the volvulus of the colon, the most common is the sigmoid colon. Usually seen in which type of the patient? Usually seen in the old age of the 6 to 70 years. It can be a clockwise also and the anti-clockwise also, but most commonly the torsion will be the anti-clockwise. The patient may be a patient of chronic constipation and usually seen in the old age people. They are on some psychiatric treatment, okay, or they are taking some opium group of the drugs. Okay, so these are some of the causation for the sigmoid volvulus. The clinical feature is constipation, and there is an abdominal pain and the obstruction, failure to pass the feces and the flatus. So pain, especially in the lower abdomen, severe abdominal pain, then the vomiting because there is a twisting, if there isn't some gangrene occurs, and there isn't fever strangulation also, the maybe high rise of temperature is there, but the most common symptom is pain and the vomiting plus obstipation. Okay, and what you will see in the x-ray of the sigmoid volvulus, ये important है, a coffee bean sign. Okay, the dilated sigmoid colon, that is your coffee bean sign, and the bird beak appearance. Bird beak appearance, it's also seen in the, I think, your gastric, in esophageal achalasia cardia. Okay, and it is also seen in the sigmoid volvulus. ठीक है, तो ये दोनों important है, coffee sign and the bird beak appearance. It is seen in sigmoid volvulus. Bird beak appearance, it is also seen in your achalasia cardia. Okay, so these are some of the important sign in case of sigmoid volvulus.
मैम
So
वो एंटी क्लॉकवाइज क्लॉकवाइज दोनों हो सकता है, पर कॉमन है
हाँ, दोनों हो
एंटी।
सकता है, बट मोस्टली द एंटी क्लॉकवाइज इज मोस्ट कॉमन. क्लॉकवाइज भी हो सकता है, एंटी क्लॉकवाइज भी हो सकता है, बट मोस्ट कॉमन इज एंटी क्लॉकवाइज. ओके, सो यस, आप लोग का नेक्स्ट साइन, नेक्स्ट क्लास कब है इसके बाद?
कल।
अच्छा, यही मेरा लास्ट क्लास है क्या? दिस इज योर लास्ट क्लास है? ओके, ठीक है. ओके, ओके, नाउ मूव टू दी, ये हो गया. एंड नाउ लेट्स intestinal obstructions. अभी करेंगे या फॉर द नेक्स्ट क्लास? Because it will be a take time. Small intestine है, Crohn's, ulcerative colitis, rectum and anal canal. You want to do it right now or we will do it later in the next class? इसी टाइम चलो ले लेते हैं एक, ठीक है, अबाउट द स्मॉल इंटेस्टाइन. इसमें से इंपॉर्टेंट जो है दैट इज ऑल अबाउट योर Meckel's diverticulum. Okay, what is Meckel's diverticulum? Usually what happen in the early stage of the development, the yolk sac, it gets its nutrient, the embryo, especially the embryo gets its nutrient from the yolk sac. ठीक है, तो suppose ये, and this is the embryo. Okay, so ये एक duct, it's directly get its nutrition from the yolk sac from a duct. Okay, this is known as your omenophalomesenteric duct or the vitelline duct. Okay, now 6 to 7 week of the gestation, the source of nutrition become placenta, and this vitellointestinal duct, it regresses by its own. ठीक है, जो जब शुरुआती में इन द अर्ली स्टेज ऑफ डेवलपिंग, जब एम्ब्रॉयड डेवलप होता है, उस समय एम्ब्रॉय को जो खाना पीना जो भी हो, द न्यूट्रिशन इट कम्स फ्रॉम द यॉक सैक. ठीक है, थ्रू अ vitellointestinal duct. When the fetus grow and after 7 to 8 week or 6 to 7 week, this vitellointestinal they start to regress and the nutrition become directly from the placenta. Meckel's diverticulum क्या है? If there is an incomplete obliteration of the vitelloinophalangistic duct, means if it is does not get regress, this is your Meckel's diverticulum. ठीक है, it is a common congenital abnormality of the small intestine. ठीक है, this due to what? Due to the incomplete obliteration of the vitelline intestinal duct. Okay, so ये दूसरा MCQ. Okay, question 2. अभी इसमें rule of 2 याद रखना. Especially what is the rule of the true, and it is a true diverticulum. It contains all the layer of the small intestine, mucosa, submucosa, mucosa layers, everything. Okay, and it is rule of the 2 is your, especially in the 2 years of old child, the 2 feet from the ileocecal valve, 2-inch long, 2% of the population. Okay, so ये rule of 2 याद रखना. Usually they are asymptomatic. Sometimes they present with painless bleeding. Okay, sometimes they present with the painless bleeding. And most common is here, hemorrhage is the most common symptom, usually seen in the children of less than 2 years of age. Less than 2 years of age. ये सब इंपॉर्टेंट है. हाँ, ये पूरा MCQ बेस्ड है, ये पूरा इंपॉर्टेंट है. डायग्नोसिस by the Meckel scan. ठीक है, न्यूक्लियर मेडिसिन स्कैन और द Meckel's scan. Okay. So most commonly, if it is in the adult, agar suppose Meckel's diverticulum, because it is asymptomatic, usually chalo grow ho raha hai, nothing is there. But sometimes in the adult also, if it is found, the most commonly in case of adult, if you find, the most common symptoms will be the intestinal obstructions. The symptoms of intestinal obstruction you will find in adult, whereas the most common symptoms in the children is the bleeding. Okay. So this is all about your Meckel's diverticulum. Men and women has an equal manifestation. Okay. Now come to the interstitial atresia. So obviously, interstitial atresia, the most common site is the duodenum. Okay. If the question asks what is the most common site of the intestinal atresia, your answer will be duodenum. So if there is an atresia, if there is an stenosis, okay, so what in the duodenum, all the symptoms of the intestinal obstruction, neonatal intestinal obstruction, you can see in the children. Okay, so it is specially intestinal obstruction, especially in the incidence is about 1 to 300 to 500 live birth. Okay, so if there is an atresia, if there is an some type of the stenosis in the intestine, the infant will be complain of this bilious vomiting. Okay, because pyloric end के नीचे है, so the bilious vomiting is the first symptoms usually present in the infant in the first day of the life. Obstruction जितना higher होगा, earlier the vomiting symptoms of the vomiting भी उतना जल्दी आएगा. ठीक है. Now suppose if the atresia is in the like this part, ठीक है, stenosis is in the this part, जितना proximal, so the most common will be the symptoms will be the vomiting. Okay, जितना distal, if there is an atresia in this part, this part, the most here the common symptoms will be the abdominal distension. Okay. So abdominal distension is the most common symptoms if the obstruction is in the distal part, and if the obstruction is in the proximal part, the most common symptom is the vomiting. Okay? How can diagnose from the ultrasonography? From the prenatal ultrasonography. Okay. So this is all about your intestinal atresia. Okay. एक मिनट. Anybody have any problem up to this?
मैम
Hello?
पिछले स्लाइड में 1:300 वो वाला मैं सुन नहीं पाया था.
अच्छा, कौन सा स्लाइड?
पिछली स्लाइड में
ओके, 1 to
1:300.
300 to 500 लिव बर्थ, मतलब रेशियो कितना है? अगर 300 से 500 लिव बर्थ होते हैं तो किसी एक या दो में ही इंटेस्टाइनल एट्रोफिया के पेशेंट आपको मतलब बच्चे मिलेंगे. दैट्स इट्स ओनली थिंग. ओके, सो इंसिडेंस इज कॉमन इन बोथ इन द मेल एंड द फीमेल. ऐसा नहीं कि फीमेल में ज्यादा है या मेल में ज्यादा है. मेल एंड फीमेल हैज एन इक्वल incidence, but in live birth the ratio is 1:300 और 1:500. इस तरह से 500 बच्चों में से किसी एक बच्चे का होगा. दैट इज द ओनली थिंग. है ठीक है.
और मैम डाइवर्टिकुलम में वो कितना वीक में ये हो जाता था वो एक बार बताइएगा तो.
कौन सा?
मिकल डाइवर्टिकुलम में जो ये
ये
था
वाला ना,
विटिलियन
यस।
डक, विटिलियन
सो
डक कितना दिन में?
सपोज, हाँ, सो बेसिकली आई थिंक 6 to 7 वीक है, ठीक है।
ओके।
सो
ओके मैम।
ये तो समझ में आ गया ना,
हाँ
दिस
हाँ
वन।
हाँ हाँ।
ये
हाँ।
तो बेसिकली विट्रोलो इंटेस्टाइनल ट्रैक्ट दे यूजुअली रिग्रेसेस बाय 6 to 7 वीक है। तो 6 to 7 वीक में क्या होता है, द सोर्स ऑफ न्यूट्रिशन बिकम योर प्लासिंटा, ठीक है। अगर ये विट्रो इंटेस्टाइनल ट्रैक्ट रिग्रेस नहीं होता है, रह जाता है, देन इट रिजल्टिंग इनटू द मेकल्स डाइवर्टिकुलम, दैट्स इट, ठीक है। ओके,
ओके मैम।
एनीथिंग और कुछ? तो मैं भी कंप्लीट इसको वाइंड अप करूंगी, ओके, बिकॉज एट ए स्ट्रेच बहुत ज्यादा हो जाता है। एंड इन द नेक्स्ट क्लास वी विल फिनिश एंड वी विल स्टार्ट विद के हार्निया भी है, हार्निया इज ऑल्सो वेरी बिग पार्ट, ओके। हार्निया है, रेक्टम एनाल कैनाल है, बहुत सारा भी बाकी है जीआईटी का, ठीक है। एनीथिंग यू वांट टू आस्क? ओके, so shall we wind it up for today? Hello, am I audible to you all? आप लोग कुछ बोलो, नहीं तो समझ में नहीं आता है।
मैम एक वाला पोर्शन था जो एक बार फिर से अगर बताते तो अच्छा
कौन सा
रहता।
वाला?
मैम वो जो जैसे स्मॉल इंटेस्टाइन का भी एक था ना मैम, मैकेनिकल एंड नॉन मैकेनिकल ऑब्स्ट्रक्शन,
हाँ,
वो एक बार फिर से थोड़ा सा।
ओके। ये स्मॉल इंटेस्टाइन का मैकेनिकल एंड दी नॉन मैकेनिकल, ठीक है। देखो, स्मॉल बाउल ऑब्स्ट्रक्शन हो या लार्ज बाउल ऑब्स्ट्रक्शन हो, ठीक है, ऑब्स्ट्रक्शन दो टाइप का होता है, वन इज योर नॉन मैकेनिकल एंड अदर इज योर मैकेनिकल। नॉन मैकेनिकल को हम लोग ए डायनेमिक बोल सकते हैं, सूडो ऑब्स्ट्रक्शन भी बोल सकते हैं। नॉन मैकेनिकल में जो होगा ना, तो मेन इज योर पैरालिटिक फीलिंग ऑफ द इंटेस्टाइन, इतना याद रखो। इंटेस्टाइन स्लगिश हो जाता है, स्पेशली न्यूरोमस्कुलर अगर कुछ प्रॉब्लम हो गया हो, अगर कुछ इन्फेक्शंस हो गए हो, ठीक है, एंड एज ए रिजल्ट पेरिस्टाल्टिक मूवमेंट डिक्रीज हो गया हो। वेर इज मैकेनिकल, देयर इज समथिंग, देयर इज सम ट्यूमर हो सकता है, कोई एडिशन हो सकता है, ठीक है। ज्यादातर क्या देखा जाता है, आफ्टर पोस्ट ऑपरेटिव के बाद, आफ्टर पोस्ट ऑपरेटिव द पेरिस्टाल्टिक मूवमेंट दे बिकम स्लगिश, ओके। जिसके कारण भी सूडो ऑब्स्ट्रक्शन और ए डायनामिक ऑब्स्ट्रक्शन हो सकता है, दैट इज नोन एज योर नॉन मैकेनिकल। बट द मैकेनिकल इज मोस्टली ड्यू टू सम लाइक ग्रोथ, कोई पॉलिप हो गया, कोई ऑब्स्ट्रक्शन हो गया, समथिंग मैकेनिकल, ओके। दिस इज द ओनली डिफरेंस बिटवीन द नॉन मैकेनिकल और द मैकेनिकल और द डायनामिक इंटेस्टिनल ऑब्स्ट्रक्शन। और कुछ?
ओके मैम, हो गया।
और कुछ नहीं पूछना है ना? लेट्स सी, और कुछ तो नहीं है ना? ओके, सो खत्म करें अभी इसको। एनीबडी, किसी को कोई स्लाइड वगैरह मिस हुई है तो बोलो। हेलो, चलो देन, ओके। So in the next class, we will do the rectum, anal canal, hernia, Crohn's disease, ulcerative colitis, ये सब बाकी है. And after that, we will start the. Uh, do you want me to start the kidney part or the general surgery? क्या आपको लगे कि start करना चाहिए? Shall I go with the general surgery or with the uh, genitourinary tract? Anybody have any suggestion? कौन सा करवाऊं? General surgery. Okay, so after finishing this, I will move to the general surgery. Okay, general surgery will take some time. Okay, so thank you all. We will meet on the next Saturday or Sunday. We will let you know. We will finish this GIT and then we will move to the general surgery. Okay, so thank you everyone.